Now we'll start with liver disorders like Wilson's disease, liver transplantation, drug-induced hepatitis, and all. So these are the other topics which we now will come across. Wilson's disease, it is also known to cause lenticular degeneration. It is an autosomal recessive disorder. Degenerative changes are seen in liver, brain, cornea, and rarely kidneys. It is fatal if untreated. Any signs of chronic liver disease in a more than 5 years old child, we should investigate always for Wilson's disease. Abnormal gene is present on chromosome 13, defective mobilization of copper from the liver cells into the bile. Copper is not properly incorporated into the hepatic proteins, that is ceruloplasmin, because of its decreased levels of this protein. So basically, there is deficiency of ceruloplasmin due to chromosomal problem. This causes diffuse accumulation of copper inside the liver. This unbound copper escapes the liver and enter into blood and reaches other organs. The excess copper in the liver damages the hepatocytes by oxidant injury, causing altered function. This copper also damages other organ cells by hampering various pathways. The common age of presentation is more than 5 years. There is a hepatomegaly with or without splenomegaly. Chronic hepatitis or fulminant hepatic failure may set in. Portal hypertension, ascites, edema is seen. Other effects of delayed puberty, anemia, coagulation defects will be seen. CNS symptoms: patient may have intentional tremors, dysarthria, poor school performance because of the basal ganglia involvement. Behavioral changes: KF ring is seen, that is case of pressure ring, on slit lamp examination of the eyes. Signs and symptoms of hemolysis may be seen. Kidney, Fanconi's syndrome, renal tubular acidosis may be found because secondary involvement of kidney. Pathology, the exact pathology is the hepatocytes. They are seen as ballooned hepatocytes and enlarged Cooper cells. The estimation of ceruloplasmin will be done, which is low. Urinary copper will be high, more on chelation. Liver biopsy will show more copper content, more than 250 microgram per gram of dry weight. Fundus will show KF rings, and genetic counseling should be done or genetic study should be done. The treatment is D-penicillamine. It is a copper chelating agent, binds copper and leads to rapid increase in excretion of excess copper. Dose is 1 gram per day in two divided doses before meals, while in children it is zero point 0.5 to zero point 0.7 grams per day. Vitamin B6 should be given. Zinc can be added. Avoid copper-rich diet like fish, chocolates, liver, nuts. They should be avoided. Indian childhood cirrhosis also mimics Wilson's disease. It is known as cirrhosis of liver other than Wilson's disease, in which copper metabolism abnormalities are present. It occurs predominantly in rural areas. ICC has been linked to excess of dietary copper ingestion primarily through the use of contaminated copper utensils. Clinical features are Indian childhood cirrhosis, jaundice, pruritus, lethargy, hepatomegaly. Pathologically, patient has hepatocyte necrosis and Mallory bodies. Increased hepatic copper content, more than 750 microgram per gram of dry weight is seen. If not treated, mortality in 45% in 4 to 7 weeks of appearance can be seen. Treatment is D-penicillamine in same doses as Wilson's and will decrease the mortality by half. Clinic Neonatal cholestasis, it is defined as prolonged elevation of serum levels of conjugated bilirubin beyond the 14 days of life, and conjugated bilirubin more than 2 grams per deciliter or more than 20% of the total serum bilirubin. Multiple etiologies are found. Jaundice beyond neonatal period, patient will have dark urine, pale stools, hepatomegaly, signs of IUGR or small for date. Genetic abnormalities may or may not be seen. Signs of liver failure in the form of portal hypertension, ascites, sick look. These are all commonly seen in intrahepatic cholestasis. These are the differences between neonatal hepatitis and biliary atresia. Onset anytime in the neonatal period, biliary atresia end of first week. Jaundice is mild to moderate in Biliary in neonatal hepatitis, it is moderate to severe in atresia. Stools are variable in hepatitis; they are clay colored in atresia. Feeding is normal or slow in neonatal hepatitis. It may be normal in atresia. Hepatomegaly is early seen in hepatitis, late in atresia. Urine urobilinogen is present in hepatitis, absent in biliary atresia. Stercobilirubin present in hepatitis, absent in atresia. SGPT is severely deranged in neonatal hepatitis. It is mildly deranged in atresia. Then Australia antigen may or may not be present in hepatitis. It is negative in atresia. Biopsy, operative cholangiography will be, means cholangiography will be normal in hepatitis. It is block is seen in atresia. So these are all the differences. Syndromes associated with extrahepatic biliary atresia are Watson-Alagille syndrome and Zellweger syndrome. Common investigations are CBC, malarial parasite, LFT, KFT, torch infection, Australia antigen, hematological profile, urine stool metabolic studies, echo, USG, genetic studies, and endoscopic cholangiography, and liver scintigraphy. Cholestasis in older children, acute and chronic viral hepatitis, drugs, Wilson's disease, alpha-1 antitrypsin deficiency, inflammatory bowel disease, autoimmune hepatitis, polylithiasis, tumors, and lymph nodes causing obstruction can lead to cholestasis. Treatment is similar. Now, this is very important point. Drug-induced liver injury. We should always be aware of which drugs are going to cause liver injury. Liver is the main site of drug metabolism and is susceptible to structural and functional injury. Drugs through ingestion, parenteral administration, inhalational environmental toxins, and herbal drugs can cause liver injury. Signs and symptoms can range from asymptomatic biochemical abnormalities of liver function to fulminant hepatic failure. Hepatic metabolism is mediated by enzymes which transform toxic products to less toxic substances and excreted in bile. Phases are three: phase 1, phase 2, and phase 3. Drugs causing alteration of membrane lipids, usually they cause alteration of the membrane lipids. They interfere with the metabolic pathways of the liver cell and causing hepatocyte injury. The common drugs leading to injury are acetaminophen, that is paracetamol, antitubercular drugs, anticonvulsants, anti-cancer drugs, sulfonamides, estrogens, and anabolic steroids, etc. Drug-induced liver injury clinical features are fever, malaise, arthralgia, jaundice, hepatomegaly. Lab diagnosis is done by liver function test, which is increased, coagulation factors go down, albumin is decreased, ammonia may be seen increased, liver biopsy can be done. Treatment, we have to stop the drugs, give steroids, and acetylcysteine and overdose of acetaminophen. So this is the common approach for drug-induced hepatitis. Just to know, sensitize metabolic liver disease, what are they? The different metabolic disorders are carbohydrate metabolism leading to liver disease are galactosemia, fructose intolerance, glycogen storage disease. Amino acid metabolism disorders are tyrosinemia, arginemia, urea cycle defects. They are amino acid metabolism disorders. Fat metabolism, Gaucher's and Niemann-Pick's disease are the common ones. Bile metabolism is Zellweger syndrome. Bilirubin metabolism disorder is Krigler-Najjar, Dubin-Johnson, and miscellaneous is antitrypsin deficiency. Clinical features are vomiting, failure to thrive, short stature in case of inborn errors of metabolism, dysmorphic features, edema, NSRCA, jaundice, hepatomegaly, acute liver failure or signs of chronic liver failure and coagulopathy. Hypoglycemia, hyperammonemia, delayed milestones, neuropsychiatric symptoms. May sometimes CCF may be seen, cataracts, body odors, etc. So this is in short about just a very short note on inborn errors of metabolism. All the clinical features are same, but the ultimate answer for inborn errors of metabolism, the treatment is liver transplant and genetic counseling. Liver transplant, a short note. It is now a standard therapy for end-stage liver disease. Indications for liver transplant are biliary atresia, alpha-1 antitrypsin deficiency, Wilson's disease, autoimmune hepatitis, cystic fibrosis, tumors, neonatal hepatitis, and others. Contraindications are HIV, irresectable hepatic malignancy, irreversible neurological disease. Management before and after the transplant. Before, We have to maintain the nutrition, give vaccination, treat the initial disease. After the liver transplant, steroids are being given, cyclosporin as a thioprine, and we have to be alert for the complications like fluid shifts, electrolyte imbalance, renal failure, hypertension, non-functional grafts, vascular problems like thrombosis, and graft rejection. Well, a few things about portal hypertension. Splenic vein plus superior mesenteric vein, they join to form the portal vein. Portal venous pressure should be between 5 to 10 millimeters of Hg, measured by ultrasound Doppler with Doppler. Portal hypertension is said when portal venous pressure is more than 10 to 12 millimeters of Hg, and extrahepatic portal hypertension is the most common cause of portal hypertension. Must present to say that it is a portal hypertension is PVP more than 10, variceal bleeds, splenomegaly, ascites, and visible tortuous veins on anterior abdominal wall from umbilicus, which is called caput medusae. Clinical features of portal hypertension are GI bleed, that is hematemesis, melena, ascites, splenomegaly, caput medusae, anemia, shrunken hard liver, dilated veins over the back, especially in veno-occlusive disease, and history of umbilical sepsis or catheterization can be asked. Diagnosis is done by upper GI endoscopy, barium swallow, USG with Doppler and portal angiography. Treatment for a case of portal hypertension, we have to resuscitate if that child has massive vomiting or hematemesis. Blood products should be given. Vitamin K should be given to stop the bleeds. NG tube should be put. Zinc taken tube to stop the bleed. Ranitidine, pharmacotherapy by octreotide can be started. Balloon tamponade to decrease the bleeding. Sclerotherapy to stop the bleeding or ligation of the vessels. But the patient, if not responding, liver transplant is the ultimate answer. Thank you very much. The next topic will be liver failure.